Welcome everyone to a recorded session on neurophysiology. Yesterday we had a few uh, explanations on the connections of the basal ganglia. I understand some people were not following the explanations, or maybe it was a bit confusing, but the connections in the basal ganglia is very simple. We have two types of connections. We have inputs to the basal ganglia, and we also have outputs to the basal ganglia, or from the basal ganglia. So the inputs to the basal ganglia, we start with the cerebral cortex. The cerebral cortex. So the cerebral cortex has connections with the striatum of the basal ganglia. So the areas of the cerebral cortex that controls movement, including the precentral motor cortex, the supplementary motor cortex, and the premotor cortex, send axons to the basal nuclei, primarily the putamen. Remember, when we're talking about the components of the basal ganglia, we know the caudate nucleus and the putamen makes up the striatum, the corpus striatum of the basal ganglia. So for the first input, we have the cerebral cortex, the areas that controls movement, sending axons to the basal nuclei, primarily the putamen, via the cortical striate pathways. So the pathway between the cerebral cortex and the striatum contains excitatory neurons that secretes glutamate. So that pathway is known as cortical striate pathway. And also there are axons from the intralaminar nuclei of the thalamus, to the striatum via the thalamo-striatal pathway. That is the pathway, thalamo-striatal pathway. Then cortical striate pathways. So we move to the next slide. So both the cortical and thalamic axons, the thalamic axons to the striatum and the cortical axons to the striatum, release excitatory neurotransmitters known as glutamate, which stimulates the putamen of the striatum. Most of these connections from the cerebral cortex to the thalamus ends in the putamen, because putamen and the caudate nucleus make up the striatum. Still on the inputs to the basal ganglia. So these are the two main inputs to the basal ganglia, and they are both excitatory. Outputs from the basal ganglia. The two major outputs from the basal ganglia are from the globus pallidus interna and the substantia nigra. The substantia nigra pars reticulata here. That's the substantia nigra pars reticulata. Remember, we are on the outputs now. We are finished with the inputs. So the two major outputs are from the globus pallidus internal segment here and the substantia nigra pars reticulata. So they are the two main outputs. They send the outputs to the thalamus. And both substantia nigra pars reticulata, pathway to the thalamus, and the globus pallidus internal segment to the thalamus are both inhibitory. They are GABAergic. The neurons between these two structures, between globus pallidus and thalamus, substantia nigra pars reticulata and thalamus, the neurons there are inhibitory. The neurotransmitter there is GABA, and both of them project to the thalamus. So that's the output. So still on the output, we have from the thalamus here, there is an excitatory, presumably glutamate secreting neurons from the thalamus to the prefrontal and premotor cortex. Remember, these parts of the cerebral cortex, motor cortex, are also involved in planning of movement, voluntary movement. So there is an output from the thalamus to the cerebral cortex, mainly the prefrontal and the premotor cortex. So to summarize that, this completes a full cortical basal ganglia thalamic cortical loop. So the input from the cerebral cortex to the striatum, the projections of the striatum to the globus pallidus, substantia nigra, pars reticulata, and the communication of these two structures with the thalamus and the feedback via the thalamocortical pathway makes up the motor circuit. So this motor circuit that we have seen within the basal ganglia, the motor circuit here, that's mainly the inputs and the outputs into the basal ganglia and out of the basal ganglia, allows intended movements to occur while inhibiting unintended movement. So that is the purpose of this circuitry, or for this loop. So we move to the next slide. And also I wanted to add something. There is also a GABAergic system that exists here between the striatum, the globus pallidus, the substantia nigra, pars reticulata, and the thalamus. So you can see there are GABAergic neurons here between the striatum, the globus pallidus, internal segment, the substantia nigra, pars reticulata, and then the communications of both the structures with the thalamus. So you can see the GABAergic neurons present between all these structures around here, from the striatum to the globus pallidus, internal segment, to the substantia nigra, pars reticulata, and then feeding into the thalamus. So that is the GABAergic system here. Don't forget the functions of the motor circuit in the basal ganglia, that it allows intended movement to occur while inhibiting unintended movements. So that takes us to connections within the basal ganglia. Connections within the basal ganglia. So the connections within, we have seen the input and the output. Now let's look at the connections within. So these connections includes the dopaminergic nigrostriatal projection from the substantia nigra pars compacta to the striatum. Remember, the striatum is made up of the caudate nucleus and the putamen. So there is a projection of the dopaminergic neurons between the substantia nigra pars compacta to the striatum. That pathway is known as the nigrostriatal pathway. So that is the pathway, that is dopamine there. So there is also a GABAergic projection from the substantia, from the striatum to the substantia nigra pars reticulata. This is substantia nigra pars reticulata. And that is the neurons present in that connection are GABAergic neurons. The neurotransmitter there is GABA, gamma aminobutyric acid. So note there are two connections there between substantia nigra pars compacta that projects to the striatum in a nigrostriatal pathway with dopaminergic neurons, and between the striatum to the substantia nigra pars reticulata via the GABAergic pathway. So still on the connections, there is also an inhibitory connection or inhibitory projection from the striatum to the globus pallidus external segment. There is an inhibitory projection via GABAergic neurons and also to the globus pallidus internal segment. So you can see GABAergic neurons projecting from the striatum, which is made up of the caudate nucleus and the putamen, and then the striatum projects to the globus pallidus external and the globus pallidus internal segment. That is also connections within. So connections within the basal ganglia still continues when we have the subthalamic nucleus in the diencephalon receiving inhibitory input from the globus pallidus external. And in turn, the subthalamic nucleus here has an excitatory glutamate projection, glutamate pathway to the globus pallidus internal segment and also to the globus pallidus external segment. So you can see the subthalamic nucleus receiving inhibitory input from globus pallidus external, and then in turn it projects excitatory projections to globus pallidus internal segment and also projects the same excitatory output to globus pallidus external via glutamate projections. And then from globus pallidus external, it is projected to subthalamic nucleus via the GABAergic inhibitory pathways. So that same subthalamic nucleus also projects to the pars compacta of the substantia nigra. The same subthalamic nucleus projects to the pars compacta of the substantia nigra, but that connection was not shown in this illustration here, but have it in mind, there is a projection between the subthalamic nucleus and the substantia nigra pars compacta. So summary of the connections, the principal connections within the basal ganglia is shown in this diagram here. So the solid lines you are seeing here indicates excitatory pathways, whereas the dashed lines, where you have GABA, mainly GABA, shows inhibitory pathways there. So acetylcholine within the striatum, acetylcholine is a neurotransmitter within the striatum. Remember, the striatum consists of the caudate nucleus and the putamen. So acetylcholine is the excitatory neurotransmitter produced by the interneurons of the striatum. And also the PPN is pedunculopontine nuclei, which is located in the upper pons, which receives input from the globus pallidus internal segment and also projects after receiving inhibitory feedback from the globus pallidus internal segment. It projects to nuclei in the brainstem and the spinal cord for the control of the voluntary or skeletal muscles. So we have seen the functions of the basal ganglia. The functions of the basal ganglia. In summary, we have the functions of the basal ganglia to be integration and regulation of motor activities. Although we are not going into the functions of the basal ganglia today, you can read up the functions of the basal ganglia I only wanted to explain to you the circuitry within the basal ganglia, the input and the outputs of the structures, and then also the connections within the basal ganglia and the neurotransmitters that are involved. So let's run to the diseases of the basal ganglia. Let's see how the inputs and the outputs and the connections within the basal ganglia, when they are disrupted, what happens? How does it bring about the diseases of the basal ganglia? So that takes us to this segment of diseases of the basal ganglia in humans. So there are three distinct biochemical pathways in the basal ganglia, as we have seen in the previous slides when we were looking at the connections in the basal ganglia. So remember the nigrostriatal dopaminergic pathway from the substantia nigra pars compacta to the striatum. And also remember, I told you about the intrastriatal cholinergic system, that the interneurons within the striatum produces acetylcholine as an excitatory neurotransmitter. Remember, the striatum is made up of the caudate nucleus and the putamen, and also the GABAergic system that I said, which projects from the striatum to the globus pallidus, and then the substantia nigra. Look at the GABAergic system projecting to the globus pallidus internal segment. From there, it projects, the globus pallidus itself projects with same GABAergic neurons to both PPN and thalamus. And the striatum also projects GABAergic neurons to the substantia nigra pars reticulata, and it also projects GABAergic neurons to globus pallidus external segment. So that is the GABAergic system. So we have three distinct biochemical pathways in the basal ganglia. We have the nigrostriatal dopaminergic system, which is both excitatory and inhibitory to the striatum. We have the intrastriatal cholinergic system. Then we also have the GABAergic system from the striatum to the globus pallidus, internal segment, external segment, and the striatum to the substantia nigra pars compacta. So those are the three distinct biochemical pathways. So in the next slide, I said, when one or more of these pathways listed, be it the striatal system, the dopaminergic nigrostriatal system, the GABAergic system, when one of these pathways listed in the slide previously is dysfunctional, there will be characteristic motor abnormalities. So those pathways need to function with one another. They need to function in compensation with one another. If one of the pathway becomes dysfunction, the other pathway will overexcite or over-inhibit the other components of the basal ganglia. That will lead to characteristic motor abnormalities. So that took us to hyperkinetic and hypokinetic features of diseases of the basal ganglia. So when there is a dysfunction in any of those three biochemical pathways, there will be features of hyperkinetic and hypokinetic disorders. So in hyperkinetic conditions are those in which the movement is excessive and abnormal, including chorea, atitosis, and bolism, which we explained yesterday. Then in hypokinetic abnormalities includes akinesia and bradykinesia, slowness in movement, and difficulty in executing movement, voluntary movement. So we have seen all the atitosis, chorea, atitosis, hyperkinetic and hypokinetic features of diseases in the basal ganglia. So we saw all of them in the previous session that we had. So we also have other disorders known to involve the malfunction of the basal ganglia. Remember, the malfunction has to include the three distinct biochemical pathways that we have seen, the connections that we have seen in the basal ganglia. Those connections have neurotransmitters. So that's why they are biochemical pathways. So we see Huntington's disease and kernicterus. So the Huntington's disease is a kind of a human genetic disease that affects the nervous system, characterized by repeats in the trinucleotide base pairs instead of the normal dinucleotide base pairs in the structure of the nucleic acids. In Huntington's disease, the subject exhibits trinucleotide repeat expansion. So instead of having adenine and thymine, guanine and cytosine as base pairs in the nucleic acid, there is a repeat of trinucleotides, cytosine, adenine, guanine repeats. And sometimes it can involve cytosine, guanine repeats and other repeats of nucleotide base pairs. But in that, when it comes to the features of Huntington's disease, what happens in the basal ganglia? We have degeneration of neurons that secretes GABA in the corpus striatum and the substantia nigra. Now you have seen the defects in the dopaminergic pathways between the corpus striatum and the globus pallidus. So there are degeneration of neurons that secrete GABA. Remember, GABA is an inhibitory neurotransmitter. So, and also in degeneration of neurons in the substantia nigra. Remember the substantia nigra, nigrostriatal pathway, which projects to the corpus striatum. So degeneration of neurons secreting GABA in corpus striatum and also the substantia nigra. Substantia nigra also pars compacta and pars reticulata. There is a degeneration of neurons in the substantia nigra pars reticulata pathway. So this degeneration of neurons is characterized by chorea, hypotonia, and dementia in subjects with Huntington's disease. In some severe cases, there is bilateral wasting of the muscles. So we also have kernicterus, which occurs as a result of hyperbilirubinemia in infants. The bilirubin crosses the blood-brain barrier, and then the basal ganglia is affected in kernicterus. So kernicterus is a syndrome that is brought about by acute bilirubin encephalopathy. So the basal ganglia are the main parts affected in the brain. So once the basal ganglia is affected, motor coordination and integration and regulation of motor activities in the infant will be impaired. So in healthy individuals, the basal ganglia output is inhibitory via the GABAergic nerve fibers. The GABAergic nerve fibers, the output from those nerve fibers is inhibitory in the GABAergic system between the corpus striatum and the globus pallidus and the substantia nigra pars reticulata. So the dopaminergic neurons that project from the substantia nigra to the putamen normally have two effects. Remember, substantia nigra pars compacta projection to the striatum has dopaminergic neurons. So dopaminergic neurons projecting from the substantia nigra to the putamen has two effects. They stimulate two receptors. And remember, the putamen is part of the corpus striatum. So the substantia nigra projects mainly to the putamen. In the putamen, there are two receptors, D1 and D2 receptors. So the substantia nigra stimulates the D1 dopamine receptors, which inhibits globus pallidus internal segment via direct GABAergic receptors, which we are going to see in the next slide. Now we are trying to zoom in to the connections between the substantia nigra, pars compacta, the striatum, and the globus pallidus. We want to see what is happening in that connection. So in that connection, we have dopaminergic receptors in the striatum, and then we have within the striatum, which is the putamen, and the globus pallidus interna, we have GABAergic receptors. So, and also the putamen, the substantia nigra pars compacta, also inhibits D2 receptors in the putamen, which also inhibit the globus pallidus interna segment. Let's see in the next slide what I'm trying to explain. So in this next slide, we see the basal ganglia output in healthy individuals. So the dopaminergic output from the substantia nigra pars compacta to the putamen, which is part of the striatum, D1 and D2 receptors. You can see the substantia nigra pars compacta here, and then projecting to the striatum. Remember, the striatum is made up of the caudate nucleus and the putamen. So here we are showing mainly the putamen because the connections is between the substantia nigra mainly and the putamen. So you can see the projections, the dopaminergic neurons projecting to the D2 and D1 receptors. To the D2 receptors is inhibitory. To the D1 receptors is excitatory. But from the D1 receptors and the D2 receptors, the output is inhibitory. So inhibitory from the D2 receptors to the globus pallidus externa segment. From there, we have inhibitory output from the D1 receptors to the globus pallidus internal segment. The globus pallidus external segment communicates with the subthalamic nucleus. From there, the subthalamic nucleus projects an excitatory output to the globus pallidus interna. So fine, the globus pallidus externa also projects inhibitory at the same time with the subthalamic nucleus to the globus pallidus internal segment. The globus pallidus internal segment now projects inhibitory output to the thalamus. The thalamus will now feed back to excite the cortex, the motor cortex. So this is the pathway that really controls voluntary movement in motor activities. So the globus pallidus internal segment also projects to the PPN, which has direct connections with the brainstem, motor nuclei, and the spinal cord. So this is the circuitry in healthy individuals, the circuitry within the substantia nigra pars compacta dopaminergic pathways, and then where with the putamen, the GABAergic neurons of the putamen and the globus pallidus, both external and internal. So the solid lines shows you excitatory pathways, the dashed lines shows you inhibitory pathways. So this is what happens in the circuitry within the striatum, the substantia nigra, and the globus pallidus in healthy individuals. So in healthy individuals, the inhibition from the globus pallidus externa, like I said, reduces excitatory discharge. The inhibition from here, globus pallidus externa, inhibits excitatory discharge from the subthalamic nucleus to the globus pallidus externa. So you can see the inhibitory discharge by way of the GABAergic pathway to the subthalamic nucleus. And then the subthalamic nucleus excites the globus pallidus interna. So in healthy individuals, the inhibition from GPE reduces excitation from subthalamic nucleus to the GPI, because the GPI will also have inhibitory output to the thalamus, which excites directly the motor cortex, which controls movement. And now the GPI also has connections with the PPN, which also synapses with motor areas in the brainstem and the spinal cord, which also controls voluntary movement. So the balance between inhibition by the GPE and the excitation from the subthalamic nucleus to the GPI and excitation via the thalamus to the cortex maintains normal motor function. Let's move to the next slide. So in Parkinson's disease, it was originally described in 1817 by James Parkinson, and that's why it's named after him. So Parkinson's disease is the first disease identified as being due to deficiency in a specific neurotransmitter. So in the 1960s, Parkinson's disease was shown to result from degeneration of dopaminergic neurons in the substantia nigra pars compacta. The fibers to the putamen, which is part of the striatum, are mostly and severely affected. The fibers to the putamen, to the D1 and D2, are the ones that are mostly affected. So this diagram shows you a comparison between what happens in the normal circuitry, thalamo-cortical basal ganglia, thalamo-cortical circuitry in the normal person, and the basal ganglia thalamo-cortical circuitry in individuals with Parkinsonism. So Parkinsonism, the connection, the output from the substantia nigra pars reticulata, the neurons degenerate, and there is no dopaminergic output to the D2 and D1 receptors of the putamen. So that will increase the inhibitory feedback to the globus pallidus external segments. And then the globus pallidus external segment inhibitory output to the subthalamic nucleus will reduce, and the subthalamic nucleus will increase its excitatory output to the GPI, globus pallidus internal segment. So there is nothing to inhibit the subthalamic nucleus from its excitatory output to the GPI. That is what happens in Parkinson's. So note here, when you see the dashed lines here compared to the dashed lines here, this one is larger than this one. So that means the inhibitory output from the GPE to the subthalamic nucleus has reduced, and that keeps the subthalamic nucleus unchecked. So the subthalamic nucleus will excite. The excitation from the subthalamic nucleus will continue to be greater. There's nothing to inhibit it as it fits to the GPI. So let's move to the next slide and see. So note that in Parkinson's disease, the dopaminergic input to the putamen is lost by the way of the substantia nigra pars compacta. So this results in decreased inhibition and increased excitation from the subthalamic nucleus. So there is a decreased inhibition from the globus pallidus externa to the subthalamic nucleus. That's the decreased inhibition. And the increased excitation from the subthalamic nucleus to the globus pallidus interna. So there's nothing to check the increased excitation from the subthalamic nucleus to globus pallidus interna, because the GPE has a decreased inhibition as a result of loss of dopaminergic input to the putamen. Remember that GPE is receiving inhibitory output from the D2 receptors of the putamen. So by so doing, the overall increase in the inhibitory output to the thalamus and the brainstem disorganizes voluntary movement. So now you can get the circuitry from the previous slide that I showed you. The overall increase in the inhibitory output to the thalamus from the GPI. Okay, now from the thalamus, from the GPI to the thalamus, and also to the brainstem by the way of the PPM increases and disorganizes voluntary movement. Let's see. So you can see here, as a result of that, the GPI increases its inhibitory output to the thalamus. That will disorganize movement. Whereas you can see the output of the thalamus to the cortex, which is supposed to be the same as in the normal. The normal is the excitatory connection to the cortex is very large, but here now it is reduced to the cortex. But from the GPI here, it is increased to the thalamus. Inhibitory is increased and is also increased to the PPN. So inhibitory output to thalamus and PPN is increased, and it will disorganize movement because the thalamus feeds to the cerebral cortex, to the motor cortex, which plans and executes movement, and also the PPN synapses with motor areas in the brainstem and the spinal cord. So since we don't have a control on the subthalamic nucleus, it keeps discharging to the GPI, and the GPI in turn increases inhibitory output to thalamus and PPN. Movement will be disorganized. Then, degeneration of the dopaminergic neurons to the corpus striatum is the main problem. So, in that aspect, dopaminergic neurons to the corpus striatum and from the substantia nigra pars compacta produces most of the symptoms. That is where the problem comes from. So once the excitatory and inhibitory output from the substantia nigra pars compacta by the way of the dopaminergic neurons to the corpus striatum, especially the putamen, the D1, D2 receptors of the putamen, once that connection is lost, then Parkinson's disease will surely manifest. So an important consideration in Parkinson's disease is the balance between excitatory discharge of the cholinergic interneurons within the striatum. The striatum will keep on putting out excitatory discharge via the D2, inhibitory discharge via the D2 receptors to the globus pallidus. But you have to consider there is an excitatory discharge within the striatum as a result of the cholinergic interneurons. So when there is an imbalance between the excitatory discharge within, they will keep on discharging in an excitatory manner, irrespective of what happens in the substantia nigra pars compacta. So what you have to consider as also another important aspect in Parkinson's is that there is also a balance between the excitatory discharge of the cholinergic interneurons and the inhibitory dopaminergic input to the striatum. So now the inhibitory dopaminergic input to the striatum is cut off from the substantia nigra pars compacta, left with only the excitatory discharge of the cholinergic interneurons. So that will bring about abnormal movement and will also contribute to the state of Parkinson's disease. So Parkinson's also have hypokinetic and hyperkinetic features. And this condition is associated with the rigidity, resting tremors, and difficulties in initiating voluntary movement. Remember the functions of the circuitry in the basal ganglia, which helps for intended movement to occur and prevents unintended movement. So there will be difficulty in Parkinson's, there will be difficulty in initiating intended voluntary movement. So we have features of Parkinson's disease here. We have hypokinetic features, hyperkinetic features there, and presentations of Parkinson's disease. Then to the treatment of Parkinson's disease, there is no treatment. Treatment of each person depends on or based on his or her symptoms. So Parkinson's disease is mostly treated with L-DOPA, which is the precursor of dopamine. Remember, it is the nigrostriatal dopaminergic neurons that have been not present that have led to the Parkinson's disease. Degeneration of those neurons have brought the problem of Parkinson's. So unfortunately, there are complications that can limit treatment with L-DOPA. Complications that include dyskinesias, involuntary movements can also occur, and in later stages, patients can develop dementia. But recent research has shown that exercise improves efficiency in dopamine uptake by modifying the areas in the brain where dopamine signals are received. Okay, that's the substantia nigra and the basal ganglia. So by modifying those areas, the nigrostriatal pathway that possesses dopamine receptors in the putamen, exercise helps in that aspect. So exercise helps to improve the efficiency of dopamine uptake in that pathway between the substantia nigra and the putamen. Okay, so exercise is very important. It's for everyone. Everyone should exercise whether they have Parkinson's disease or not. Exercise is very important. So in the pathophysiology of Parkinson's disease, there is a time between when the neurons loss begins and when Parkinson's disease symptoms start to show. When the neuron starts degenerating, it will not show. Those features of Parkinson's disease, difficulty in initiating movement, rigidity, and so on, will not show. So there's a time between when the neuron starts degenerating and when the symptom starts to show. So by the time most people are diagnosed with Parkinson's, most of the neurons, dopaminergic neurons in the nigrostriatal pathway are lost, are already gone. So the reason with people with Parkinson's disease and they don't experience symptoms until they reach this point is as a result of the brain trying to compensate for the loss of the neurons by adapting. So the brain tries to adapt to the loss. The neurons start degenerating and the brain tries to adapt to the loss of the neurons. So that is known as neuroplasticity, experience-dependent neuroplasticity. So exercise is very important because it will increase the uptake. So even if someone is predisposed to the risk factors of Parkinson's disease earlier or later in life, constant exercise will keep the neurons working, will increase the dopaminergic uptake in the pathway, in the dopaminergic pathway. And then that takes us to the causes of Parkinson's disease. Can be genetic. The factors can be genetic. It can be environmental, such as exposure to pesticides and herbicides. And also it can be drug-induced. Some drugs can induce Parkinson's, antipsychotic drugs, and also some brain conditions can induce Parkinson's disease, such as corticobasal degeneration, and also strokes can also contribute to the condition of Parkinson's disease. Thank you for your time and thank you for listening. I will take questions. If you have any concerns or any questions, you can write me in my email or you can message me on my WhatsApp. And have a nice day and stay safe. Thank you.